Okay, we have to have a slightly shorter break than normal because we have two awesome physicians that are going to be talking about some Votiva and some Body Tight. And we have our young lady that I want to show off today, review what's happened. We'll do a little bit of injectable augmentation of our energy-based treatment, but she's more of an energy-based gal, not an injectable gal. Some patients are more injectables, less energy-based. And if you want more on Get the Point webinars, which are live streamed opportunities, every one of these workshops, 30 to 40 times a year, is available online about a week after it's been done. So you see injectables, volume, lasers, different companies, all on Get the Point. There are also individual injection, high resolution stream video on all the component parts. So some patients need a bunch of zones and buttresses, some need very little. She happens to be a nice full face, not terribly animated, that needs more energy. But I'll just show you how you might analyze and complement around what we've already done. So if we take a look at our young lady here, how was your night, first of all? Reasonably comfortable?
Absolutely.
Absolutely comfortable, not too much pain or discomfort. Let's take a look at her face, zoom in on her face here. She's had, as you recall, lamella, forma, fractura. And if we look at this, that is called purpura. She's got a lot of red, ruddy tones, and she was 6 millisecond pulse duration and 18 joules per centimeter squared. I guarantee you, no other IPL in the market could do that. It's a very strong IPL, and I don't necessarily think she wanted purpura, but she's going to get a tremendous improvement in her red, ruddy complexion with that single treatment. She's got a full mid-face, not in need of volumization. She needs color correction, a little bit of tightening. If we look at her neck down here in her neck, let's take a look. Remember I said there'd be almost no bruising, and there's almost no bruising. She's going to have a very nice right angle. You can already see it happening. She's going to get skin tightening, and her turkey neck with the waddle is going to be amputated. And I don't know if you watched that yesterday. Did that look difficult? I made things look pretty easy, but it's not that difficult. It just isn't. There's tons of people that are not plastic surgeons or oculoplastic surgeons or general surgeons or cardiologists or internists or GPs doing exactly what I did yesterday, and that's revenue positive. Easy to do out of the Body Type platform with a little fractura. She's going to have a totally new neck in 10 days. No excision. Now, how do we complement that with injectables? I'd come over the man, I'd say, you know what, ma'am, you don't need a lot. You're not terribly animated, you don't pull down a lot, you don't have a loss of volume. We need to support a couple of elements. So online on Get the Point, I go through all the buttresses and how we work them, and how we address them, how we uncouple the elevators from the depressors, and how we volumize. If you look at her, zoom out and show me the whole face, there's just not a lot of need. But I walk through it with every patient. I say, well, let's talk about a brow lift, mid-face lift, and jawline lift. First of all, with your brow, lift your brows up. She's got a nice elevation, but not overarching. Relax. Be angry. Frown. Woo. She's a strong puller downer. The corrugator supercilii and the procerus pull her brow down. Now, what if we relax that and I went, ah. We emancipate the elevators from the tyranny of the depressors. You are a Botox freedom fighter. Your job is to go out and knock off depressors so the elevators can act without tonic oppression and pulling down. So we want to get her corrugator supercilii, want to get her procerus, and that's going to be about 30 units of toxin in my practice. Now, dilution doesn't matter, we're talking units. It could be twice that in Dysport and 1.5 to 1 in Xeomin. It's not 1 to 1. There goes all the price differences. Sorry, Dysport's more 4 to 1 and Xeomin's 1.5 to 1. And I keep Xeomin and Dysport around, but I use mainly Botox because that's what everybody knows. Big smile, big smile, big smile. So she pulls down a little bit here. She's got a strong orbicularis oculi crease. So look for the vertical fibers of orbicularis oculi, the center depressors, and knock them off. So I'm going to knock off her orbicularis oculi, and we should get a systemic and generalized elevation of about 5 millimeters. Just like that, a little brow elevation. Now, she has a few horizontal lines here, not many, so I want to soften them, but I want to keep the lateral frontalis completely unactivated. I want all the frontalis activity here to lift the tail of the brow and that crepey skin. So we want to elevate the lateral tail of brow, and that's a Botox brow lift. There's some under eye value, not in her. There's some nasalis in people that big smile, that squint through their nose, big smile. She's not a nasalis activator, but watch for compensatory recruitment. As you Botox her brow twice a year, maybe 3 times a year, she may start to activate nasalis and infraorbital orbicularis. So watch for that. You may have to add a unit, a unit, a unit, and a unit. So she's going to get a nice Botox brow lift. Sometimes I use a little filler in the supraorbital buttress and temporal hollow, but she's quite full there. She doesn't need it. Botox brow lifting is probably all she's going to need to give her brow. But I look at that volume compartment and I assess it. She just doesn't need it. The second buttress for volume and modulator is the under eye. Look way up in the eye air. She doesn't have, look up, open your eyes, look way up. She doesn't have a lot of hollow infraorbital issues here. But sometimes the second buttress, nasojugular and entire infraorbital buttress, needs to be volumized. It just happens to be in her. She doesn't. Now, I've got some great video online almost every weekend. That is an area we have to inject. We don't have to in her, but analyze it. So supraorbital volume, temporal hollow, infraorbital, she's good. She's fine. What we need to do is take a boxy look with a, zoom out a bit, with a bit of a jowly look to her. Give me a little more light. She looks a little shadowy there, if you can. Much better. And open her up. Get more zygomatic, high arch. She has a full malar eminence. She does not need filler face. And so to try and open her up, we can do a tiny little bit of Botox upper zygomatic arch to try and unite the side with the front. And she's got a heavy jowl, so nasolabial fold into a labiomental fold. I want to soften a bit in front of her jowl. And she's actually full right back of her jawline, so I don't have to do the retromandibular area. So in general, we're going to focus a lot of our efforts on this little buttress, which is the mandibular buttress. And I don't often inject smile lines, but when the commissures fall like that and she has sad mouth or mouth pout, I want to help support that to give her happy mouth. I want the zygomaticus major minor to take over, so I want to inject her DAO. So in the mid-face, I want ZMM, zygomaticus major minor, overcoming DAO. So I want this up, and I want to minimize the pull down. So I use a little toxin and filler to support that. Her lips could add a little bit. She's got some lines. We might augment her lip a little bit. Doesn't need anything in her nose. So that's my analysis of the buttresses. Supraorbital, infraorbital, malar zygomatic, doesn't need malar, just zygomatic. Mandibular border, mainly central. And then the beauty buttresses, the lip and the nose. So I analyze everybody. Not everybody needs every buttress. So Botox brow lifting, we're going to uncouple by injecting her DAO, and I'll talk about where I do that. I want to roll out her lateral lip with a little Botox, allowing LLS to roll the lip out, and then volumize to support. And that's it. So she doesn't need a lot of Botox and filler to supplement the laser. She needs a lot of color correction and wrinkle reduction and neck contouring. That's where the energy came in. Energy injectables, not always equal in proportion. So hand me a little Botox vial. This is our plug for Allergan. Allergan, 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 Allergan. Now, everybody knows Botox. Everyone searches by Botox. I keep some Dysport and Zima around unless they're vehemently opposed to Botox. But most of what I inject is this because people know about it. And I think they all work about the same anyway. 4-to-1 Dysport to Botox and 1.5-to-1 Zima to Botox. There's really no significant price difference. Okay. Now, how do we dilute this? Well, I take my 200-unit vial and I dilute it with 2 units, 2 cc's of preservative saline for every 100 units. So if you have a 100-unit vial, that's 2 cc's of diluent. A 200-unit vial, that's 4 cc's. I'm a 2-to-1 kind of guy. You can be 1-to-1, which would be 2 cc's. You could be 6-to-1, which would be 6 cc's. But the more dilute you get, theoretically, the wider it spreads. And the more it spreads, the more risk of dispersion onto muscle you don't want, like levator aponeurosis and ptosis, or zygomaticus major minor and a weak smile. So more concentration, usually less spread, but it's also more expensive. So I'm a 2-to-1 kind of guy. It's worked for me for 20 years. 1-to-1, 2-to-1 most common in North America. 4 or 5-to-1 more common in Europe. And so now we got to get it into a vehicle for injection. So I use a little 31 B&D needle. 31 gauge B&D needle. And this is not 30 units because I diluted it 2-to-1. If I was 1-to-1, that would be 30 units. It's 2-to-1, that means this is 15 units, not 30. So 30 down to 20 is 10, 20 down to 10 is 10, and 10 down to 0, it's 5. 30 down to 20 is 5, not 10. 20 down to 10 is 5, not 10. 10 down to 0 is 5, not 10, because it's a 2-to-1 dilution. I like that because everything I inject is about 5 units. So it's easy to measure. I don't have to measure little tiny lines. And now it's very, very, very simple. I want to get down to where it's active, and I want to do it as painless as possible. And often she'd have the option for an extra $20 to puff on a little Pronox while I'm injecting. Fine with me. Or straight up, Botox ain't very painful. Some women it's horrific. Others it's no big deal. Everybody's a bit different, so I offer them different options. But I don't administer a narcotic, of course. So now I'm going to rotate in. I'm going to get her central corrugator supercilii. I don't plunge, I engage, and then I rotate. Why? The burst strength is less. I always have a gloved hand on what's touching the skin and a non-gloved hand on what's touching the syringe, so I have better contact. I palm it in, 30 down to 20, there's 10, 5. 20 down to 10, there's 5. And 10 down to 0, there's 5. I want 15 units in a very strong vertical depressor. Gauzes, where are my gauzes? She's hemorrhaging, exsanguinating. There we go, awesome. And so there was 15 units, not 30, all in the corrugator supercilii. I don't care too much about the horizontal frown because she doesn't have a frown line. I don't mind if she moves, I don't want her to pull down. Now let's go to the contralateral corrugator supercilii. I put a little squish on it so it kind of creates discomfort, which distracts her. And I palm, meaning I use my palm with my index and my thumb in my middle. I pull back with my ring to get negative pressure, no dribbling. And so I simply rotate in, right down to the hub, because I want to get past frontalis down to the corrugator supercilii. You don't have to bounce off the bone. 30 down to 25, 20 down to 10, 5, and 10 down to 0, 5 units. So 5, 5, and 5 is 15 units. 15 units on either side. That's 30 units to quiet her pulling down muscle on either side. Now there's a central puller down, or procerus, that gives her that crunch line. Lift up. Procerus is a strong central muscle, goes from the periosteum of the nasal root to the glabella, and I go from 30 down to 20, 20 down to 10. 10 units in procerus is enough. And I've injected about 40 units in the central brow because she does that. And I want this to open up. Now, all that's working on her central brow is her frontalis. It should open up a little bit. And now we're going to do a little subcutaneous injection here, 5 units, at the top of the orbicularis oculi and in the mid-lateral canthal region. Same on the other side, 5 units. 5 units. I make these intradermal because the number one risk in the lateral orbital region is ecchymosis or bruising. So watch for those little reticular veins. So now I've knocked off this, I've knocked off that, and I've knocked off this. The brow should go, And I don't care about lines. They go along for the ride. Now I might want to modulate slightly the lininess here, and so the central frontalis stays static with about 6 units of intradermal toxin every 2 centimeters, 2 centimeters above that, and 1 just at the top. Now, what does that 6 units I just injected right here do? Well, it means this will be relatively quiet, and she'll go, in her lateral tail of the brow to get that hooded lid off her face. And that's a simple Botox brow lift. How much did I use? 40, 46, 66, 76 units. Very common for me to use 75 units to uncouple the brow. And now what do we do in the contralateral areas? Well, we leave that alone and we look at the mid-face depressor apparatus. Zoom out. Elevator, depressor. Zygomaticus major minor, depressor angularis horis. ZMM, DAO. We want to knock off DAO. In general, you come down the labiomental fold, DAO, quadrangular muscle here that inserts in the modiolus, which is the condensation of collagen in the lateral commissure. And we want the tug of war to be won by the uppers, not the downers. So we knock off the downer, DAO. You can come down the basal border of the mandible and 1 finger breadth posterior, 1 finger breadth in front of masseter, or, as I do, come down about halfway, turn 90 degrees into the DAO as it's separated 5 units already right here from the DLI. You don't want a depressor labial inferior weakness or this comes up. So once they've separated, I inject the DAO up here. Stay down well away from rhizoris. And same with the other side, down the labiomental fold, about 1 centimeter or 2, turn in, knock off DAO after it's separated from DLI and just before it inserts in the modiolus. So this knocks off this effect, allowing that effect. Next, we want to get the lip to roll out. Her upper lip could use a little bit of volume. She's got some lines there we're going to try to improve. And so we would put a little bit of Botox, 1 unit just in front of the levator labii superioris. Later, levator labii superioris will do this when OO rolls it in. OO rolls in, orbicularis oris, levator labii superioris rolls out, which is a little muscle from the periosteum, lateral nasal sidewall, down to the dermal margin of the white roll. Want to roll that out. So that should allow this and this. The last muscle I look at is depressor septinase muscle. Big smile. And she doesn't plunge her tip, but if she does, I squeeze until she anoxic and faint, and I plunge right in and get her DSN with 5 units. So 5 units, 6, 7, 12, 17 units. So 17 units in the lower face, 75, almost 100 units in her face, just to knock off mid-face and brow depressors. I haven't talked about a single corrugator, just uncoupling elevators from depressors, and the wrinkles come along for the ride. And that's it. That's Botox brow mid-face lifting, made simple. We have a little bit extra left, so what can I do that's kind of fun? I don't know. Yeah, she might bunny line, so this is prophylactic. She may have a compensatory recruitment of nasalis because she can't squint through her lateral nasal sidewall, and no one has too little procerus. Okay, so now we've done 100 units of Botox. That makes me feel a lot better. And now we're going to do some volume. She doesn't need a lot. She's got a full face. You've got to be awfully cautious. I want to correct the corner of her mouth, her labial and jowl, and I'm going to use Voluma because it lasts 2 years. I don't say that, though. I reconstitute this with lidocaine. So I take what they give me. I get some 1 cc syringes and a stopcock, open up the two-way, and add a little lidocaine. So it ends up being 50-50 mixture of lidocaine and juvie. It lasts 1 year. It opens up the molecule with the lidocaine, gets replaced by interstitial fluid, holds the volume, and dissipates in 1 year. I never say 2 years. I say, ma'am, I've added some lidocaine for comfort. It's going to last 1 year. I want to see you every year for volume. That's it. They already send it to us reconstituted. International doctors have been adding lidocaine for years. They used to send us 5 cc's of Voluma before it was bought by Allergan. We'd add a bunch of 1 cc syringes of lidocaine. So I know it lasts 1 year. And that's all I tell them. 1 year, I've added local for comfort. That means your actual syringe cost is $200, not $400, which makes the procedure a lot more affordable. Okay, back to you. How am I going to get this in? Little micro cannula. Why? Blunt tips, I think, are safer, faster, and less painful than sharp tips. And so I use a 22 gauge 2-inch for everything because this is a big, thick product. You could use a 25, but you get a lot of popping off of the micro cannula at the lower lock junction. And so you get this from Dermasculpt. They're warehoused in Miami, Florida. And you get a box of 25. They're about $5 each. I use 1 pack per patient. I take my little kit here. Now you have a needle to get you under the skin and a microcannula to navigate the supraperiosteal space. Now if you look at the configuration of this and you decide, wow, I wonder which one could cause the most likelihood of an embolism. Wow, if I want to get an arterial blood gas, that looks like the right instrument. If I want to avoid getting it in a small artery and the least likely to draw an arterial blood gas, that probably looks like the right configuration, no sharp edges. No one's ever going to prove this, but I think in a court of law, there's a lot of people that would say the microcannula is less likely to cause embolism and angioembolic events than a sharp needle. So get used to a microcannula. It's faster and it's less painful anyway. And so now I can get the lower lid, nasojugular, orbital groove from one infraorbital and go up the zygomatic arch. So my port is right here for the buttress 2 and buttress 3. To treat the supraorbital, come up and show the brow. 1 stab right here gets me along the supraorbital ridge. I turn and I go into the temporoparietal fascia. So 1 poke, 1 port, the entire buttress. 1 poke, 2 buttresses. And then 1 poke, I can get up here over the lip and up the nasolabial fold and here for the jowl. Okay, so let's go to the infraorbital buttress, rotate, stretch, park. Oop, a little bit of heme, that's okay, dab it up. We know at least she's got a carotid artery that's working. And we're going to go under the fat pad. I'm down on the periosteum, supraperiosteum. I can slide up and easily go right across her infraorbital buttress, easily. She doesn't need it, really. And I simply do little toothpicks all the way across and back. Her, I'm going to turn my direction, lift up the malar fat pad, and slide right up the malar zygomatic arch. And I don't want to do anything in her malar eminence. I want to be up her zygomatic arch. I'm using reconstituted Voluma. And so she often needs here about 1.5 to 2 cc's to create a zygomatic dominance, to take the emphasis away from her central pre-jowling. And so I'm doing little toothpicks, inject on the way back, advance, inject, advance, inject, advance, inject, advance, inject, advance, inject. Feels kind of weird. She wouldn't say it's agonizing, painful, it just feels creepy. Like someone crunching along your periosteum like season 1 of Dexter. It's kind of that kind of thing. But it is not overly painful. There's way more, like the lasers were more painful. This is just weird. Rendered way less weird with Pronox. Okay, so what do I mean by toothpick? I advance, zoom in, and I inject on the way back. And I lay down a little toothpick of gel like that. I've got thousands of little toothpicks all in their little home, all secure, because as I push, I dilate, and it closes on the way back. So very stabilized little toothpicks giving her support. Let's go to a second syringe. I want a little more buildup so it creates a little oval look to that very malar-dominant facial architecture. And again, we're going to zoom right up that malar zygomatic buttress, up the zygoma a little bit more, and put maybe a half cc in there. Little toothpicking, injecting on the way back. Very straightforward. Now, once we're done, we simply stop, look at the contour. I'm liking that. And now we're going to look at buttress number 2, which is the nasolabial and upper lip. And we go through one infranasolabial port. We remove that sharp needle so we don't use that again there. And we simply take our Juvederm reconstitute for comfort. I don't inject a lot of nasolabial folds unless they're deep. Do not go down on the bone. This is angioembolism zone number 1. Most necrosis are reported here, the junction of the nasolabial and transverse facial artery. Don't go deep. There are big vessels there. Stay a little more subcutaneous. Inject on the way back, low pressure, little aliquots, and just soften. Don't eliminate the nasolabial fold. You're not creating a monkey. Simians don't have nasolabial folds, but they don't look particularly human. You want to create an attractive human. And so inject on the way back, a little bit of Juvederm to soften her nasolabial fold, not eliminate. Soften, but not eliminate. And then I simply turn, open her mouth a little bit. I'm going to pop under orbicularis oris here with my microcannula. I pop chin up just a bit, chin up, there. Like that, beautiful, like that, beautiful. I pop through I don't usually come out. I pop through orbicularis oris. I'm under the muscle, open a bit, don't close your mouth, beautiful, open, perfect. And I'm under orbicularis oris, above the mucosa. I'm not a wet-dry junction. If you inject the wet-dry junction, it comes out at you, it's protrusive. If you increase vertical height, go way back in the wet mucosa here, and I inject on the way back. No lumps, no bumps, no bruising, no ecchymosis. Simply roll the lip out and create more wet lip show so the lip looks higher but not done. Higher but not done. Okay? And that creates a nice vertical height right down to the commissure. Relax your head a little bit. There we go. Perfect. But it doesn't look done. It just looks higher. More red lip show but not protrusion. Not ducky lip, not a trout pout, just more red lip. Now, to soften her jowl, the last buttress on this side, we're going to go through the pagonian. Stings a little bit, but so does growing old without fighting it. And we're going to go through that little sharp needle port and get under DAO and DLI, just above the periosteum. And remember your port angle. I always use about 30 degrees, so I remember. And we're going to get under that little port here. I have to make a strong enough port to actually get under. And I inject on the way back. A little bit of volume, a little bit of volume. And I'm softening that little pre-jowl sulcus so it doesn't look as jowly in front of it. Pretty straightforward concept. Soften the jowl. Very straightforward. Soften the jowl, that little pre-jowl sulcus. Okay? And soften on the way up. Excellent. And we've softened the corner of the mouth. Not done yet. Give me the Juvie and a Sharpie. This is the only time I use a sharp needle. Only time I use a sharp needle. Okay? And so we're going to use a little sharp needle, and we are going to inject along the intradermal space here, on the intradermal space. I lift where I want it to be. I lift where I want it to be. I inject intradermally, inject on the way back, inject on the way back, inject on the way back, intradermally to support almost a little 45-degree angle, support that corner of her mouth to make it horizontal and happy again. Okay, now we've restructured that entire face. Look at compared to the other side. That's a little bit of volume, about 3 syringes to support the laser that we did. Okay? And so I'm very happy with that side. I think it looks awesome. And so the next concept is, well, what are we going to do for our other side? Well, we're going to match it. And now we'll speed up. I went pretty slow. I'm going to speed up just a little bit to show you a little more real time. I come down the nasojugular groove below the malar eminence, pop through, stretch and rotate, take that painful sharp needle and park it. And now I take my microcannula. I'm going to go under the malar fat pad, turn, go right up the zygomatic arch. I'm going to put about 1.5 cc here. It feels uncomfortable, but again, I think she would say like the fractura was more painful than this is. And so this is a comfortable way to numb the face before you do some more laser. And certainly is going to change her shape and contour in addition to the lasers, but they all integrate. The laser made her skin look more attractive. This helps support the volume. The Fractora and Forma tighten her skin. It's all integrated. You need both energy and volume and toxin. Toxin to uncover and lift, volume to shape and support. Lasers to contour and tighten. A little half cc more. I want to make sure she's nicely symmetrical. And let's go up that zygomatic arch again. Okay, so about a half cc to balance her. I'm liking that. Looks quite nice here. Very nice. Nice volume, nice proportion. And now we went up the nasolabial fold. I always ask what side they sleep on. She looks like a right-sided sleeper to me because her nasolabial fold's a little deeper, a little more deep set, the downgoing mouth's a little stronger. And you can often tell a lot about a couple because couples that spoon stay together. If her husband's deflated on the other side, they don't spoon, they're about to get divorced. So inject on the way back here. A little bit more juvie. And so we're softening, not eliminating smile lines, softening, not eliminating. And we move down a little bit here. And again, soften but not eliminate. And open up just a little bit. I'm going to go under orbicularis oris, and we're going to put that same half cc on this side. Get in that right plane. It slides right out with no resistance. Inject on the way back in the wet lip. Open up the lip, but don't cause a ducky lip. No bumps, no lumps, no bruising. Nice, gentle technique. It takes a little while. Tom will be right out. It takes a little while to get into that right plane, but once you got it, you create a nice volumization, and again, nice subtle enhancement of that upper lip. She needs a tiny bit more on this side to match the other side. And then we are going to go to that last buttress, which is the mandibular border. Okay? Very nice, like that. Very good. Okay, now back to our microcannula, and we're going to soften her pre-jowl. A little stingy pagonial injection. We're going to get under her DAO, DLI, and we're going to improve that jawline. And if you could load Volbella on a 31 gauge 1 inch, we'll do a little bit of beautification at the end, not really buttress, but beautification. And give me a Voluma on a Sharpie. Beautiful. So we soften this little pre-jowl sulcus to minimize the look of her jowl and go up and support the labiamental fold a little bit. A little stingy here, but tolerable stinginess, acceptable discomfort, rendered really dopamine favorable by the use of Pronox. Again, big fan of that, which we don't have here today, unfortunately, but easy thing to look up on the internet and get them to come and do a demo. Makes your Fractora, your injectables, your lasers much more comfortable. Lift this up, 40-degree angle, support that little intradermal space here, and that looks awesome. Nice happy mouth. So look how happy she looks now. No downgoing mouth. Now we can add a little beauty on that. Why not? Now I'm going to go intradermal for only the second time. And I'm chin up just a bit. Keep that chin up. And now I'm going to take my Volbella. You could use Restylane or Bolletero. I go intradermal to help with the white roll to soften her wrinkles. I'm right in that subdermal space, right out to the Cupid's bow. Inject on the way back. Soften her lines and wrinkle. Give her a little more of that come hither young man and kiss me lip. Turn this way. Chin up. Beautiful. Right under that white roll. And so what you've seen here today is a very quick little selective volumization. This stings a little bit, so often I'll get them to open your mouth for me, bite down on this, and hold some pressure. Beautiful. Now she can't scream. And so now I go from the top of the Cupid's bow down to the bottom down to the top, and it's been a nice auditory event. Now, I'll often shorten that patchless older upper lip by going up the filthrow column, doing a little intradermal work right there. Little highlight of that filthrow column. Don't make it ridiculous. You don't want to have ridiculous lips, but open up. See, she wanted to talk and couldn't. Now, open up. Awesome. There we go. And if you look in the mirror, that's just relax, relax. A little bruise right there, which is uncommon. So she has a tiny little bruise, but that was from the sharp needle at the very end. But overall, that's a nice, natural improvement using volumization. It added up. See, there's no more jowl apparent. Her zygomatic arch is dominant. Nasolabial fold is softer, and her brow is going to go like this. Her midface is going to do that. All the laser work will kick in, and she'll look awesome in about a week. This is not a go back to work tomorrow type of thing. This is a 1 week off from her sternum to her forehead. Integration of toxin, filler, and energy. Now you've got two great speakers here, so I'll leave you with one thought, then I can't answer a single question because I don't want to miss my flight. How much would you charge for that? Start with the cost. 6 syringes, not $400 per syringe, $200 because you reconstitute for comfort. That's $1,200 your cost. 100 units, that's $600. You're $1,800 in. How much you can charge for that facial work? At least $29.99. Double down on your profit. I charge about $5,000 for that.